Hello, I'm Dr. Manish Singhal, medical oncologist at Apollo Hospitals, Noida and Delhi. We are presenting the ESMO update meeting. ESMO is European Society of Medical Oncology meeting, which was held this year in October 2023. This is a meeting which is attended by global experts across the world, and it provides all the up-to-date information about various cancers. And we are happy to announce that this meeting was held under the aegis of Apollo Hospital and was held on 4th of November at Radisson Blu, Sector 18, Noida. And we were able to invite faculty across Delhi NCR and all other cancer experts, which shared their views on these updates, and was attended by a lot of students. And I'm sure that these updates includes not only about breast cancer, lung cancer, GI cancers, gastrointestinal cancers, GU cancers, but also supportive care and sarcomas. It's so very important to keep up to date to provide the best possible care to our cancer patients. And I hope that you like these updates, and we will keep introducing more updates like this in the future. Thank you.
Good afternoon, everyone, to all present here. Thank you, Manish sir, for inviting me. I am consultant medical oncologist at ESI Hospital, Faridabad and SSB Hospital, Faridabad. Today, my topic will be triple negative breast cancer, current status and promising agents. So, coming to epidemiology, globally, over 1 million women are diagnosed with breast cancer every year. It's the most frequent diagnosed cancer in women and the leading cause of cancer death in women. Every year, more than 5 lakh women die from this disease, and death rate is steadily going down since the last decades. In 2020, 1,78,000 new cases were reported and 90,000 were reported for breast cancer. 90,000 deaths were reported for breast cancer in India. So, coming to the Indian scenario, among the all ages, as you all know, breast cancer is the most common, comprising of 26% of all the cancers occurring in females. And coming to the global scenario, the age standardized incidence and mortality rate, you can see that it comes in the top 10 cancers and is the topmost in the incidence as well as the mortality rate wise. So coming to what is triple negative breast cancer. Triple negative means ER negative, PR negative, HER2 negative, and TNBC accounts for 10 to 17% of all breast cancers, and these cancers are significantly more aggressive than other molecular subtype tumors, and they are majority grade 3 tumors and more frequently higher grade invasive ductal carcinoma of no special type. So coming to the clinical characteristics of this metastatic TNBC, coming to the relapse pattern, they have a shorter disease-free interval. There is increase in visceral metastasis among TNBC and differs from luminal cancers, like there are more of CNS involvement in TNBC. So TNBC and HER2 positive cancers have a more increase in visceral metastasis and also have a more increase in the CNS mets, as you can see from this picture. The percentage of TNBC is 74% have a visceral metastasis, and HER2 positive also have a more of visceral mets, while the luminal have more of bony mets. Now coming to the TNBC classifications, there are various types of TNBC like mesenchymal-like TNBC, immune-associated TNBC, basal-like TNBC, HER2-enriched TNBC, and luminal epicrine TNBC. Now coming to current treatment approaches for advanced TNBC. So generally we use a single agent chemotherapy for most of the patients, and double agent or combination chemotherapy increases the response rate, but it does not improve the overall survival. So the most commonly regimen which are used are taxanes, then followed by anthracyclines, antimetabolites, other later down the line microtubule inhibitors and platinum agents can be clubbed with mostly taxanes or antimetabolites. And patients should generally remain on a regimen until best response, disease progression or significant toxicity. So these are the standard doses of taxanes. Docetaxel is between 60 to 100 mg per meter square for 3 weekly regimen, and weekly is 35 mg per meter square, 6 weeks on, 2 weeks off. Paclitaxel is 175, 3 weekly. This I think all of us know. And coming to the greater adverse profile, this also we all know that more of myelosuppression and fluid retention with GI toxicity with docetaxel and with paclitaxel, more of neuropathy, and could be a allergic reaction which are lesser with NAB paclitaxel. So coming to the phase 3 trial of paclitaxel, 3-weekly paclitaxel versus docetaxel in advanced breast cancer after neoadjuvant treatment or first line of chemo, you can see there was higher improved median time to progression in OS with docetaxel versus paclitaxel. So clearly docetaxel had increased TTP and OS, but the side effects were more with docetaxel, limiting its use. Coming to the phase 2 trial, nab-paclitaxel versus docetaxel in chemo-naive metastatic breast cancer. Patients with metastatic breast cancer, no prior chemo for metastatic disease, were given in the various doses of nab-paclitaxel of 300 mg per meter square 3 weekly, 100 mg per meter square weekly, 150 mg per square weekly, and docetaxel 100 mg per meter square 3 weekly. Endpoints were overall response rate, secondary endpoints, PFS, OS, depth of response, safety. So coming to the results, the nab-paclitaxel versus docetaxel in chemo-naive advanced breast cancer, the most suitable dose of among all this was 150 mg per meter square of nab-paclitaxel, in which there was greatest response rates, and PFS was also quite high, achieved with 150 mg per meter square. And rest of the doses, either they were less among all as we compare. So you can see p-value was also significant, 0.0065 in nab-paclitaxel when 150 mg per meter square was given versus 3-weekly regimen of docetaxel. Coming to the carboplatin versus docetaxel in advanced TNBC or in BRCA positive breast cancer, patients with ER negative, PR unknown, and HER2 negative or BRCA positive metastatic or recurrent LABC were given carboplatin AUC6 3 weekly for 6 cycles versus docetaxel 100 mg per meter square 3 weekly for 6 cycles, and crossover was allowed upon progression. Primary endpoint was overall response rate, and secondary endpoints of PFS, OS, and subgroup analysis included either positive BRCA mutation or negative, or basal-like subgroups and HRD biomarkers. So coming to the overall response rates, all patients, you can see the response rates of carboplatin were more, as we all know, in the BRCA mutated arm, and they were not much significant in patients with negative BRCA mutation. And coming to the median PFS, there was not much difference between the carboplatin or docetaxel arm and the curves merged as we went ahead. Coming to the PFS by the BRCA subgroup analysis, carboplatin had a clear-cut advantage in the BRCA mutated versus non-BRCA mutated patients, and you can see the orange line, which is significantly high in BRCA mutated. Median PFS was also high of 6.8 months. Coming to the phase 2 TNACT trial, nab-paclitaxel carboplatin doublet as first-line therapy for metastatic TNBC. In patients with metastatic TNBC and no prior systemic therapy for advanced disease, who were given a dose of nab-paclitaxel carboplatin weekly with day 1/8 regime with Q21, and nab-paclitaxel or gemcitabine carboplatin were given until progressive disease. And primary endpoint was PFS, secondary was OS, overall response rate, and safety. So you can see that nab-paclitaxel and carboplatin doublet as the first-line therapy was TNBC. There clearly it was a winner among all these, and the graph of nab-paclitaxel and carboplatin was the top, is more than the other two drugs doublets. So you can see median PFS was also high with 16.4 with nab-paclitaxel compared with the others. Now coming to the phase 3 EMBRACE trial of eribulin versus for heavily pretreated metastatic breast cancer. Women with locally recurrent or metastatic breast cancer who had given prior regimes like anthracycline, taxanes, 2 were given eribulin in the standard dose of day 1, day 8, 1.54 mg per meter square, and treatment of physicians versus treatment of physician size, and was given until progressive disease or toxicity. Primary endpoint was OS, secondary endpoint was PFS, ORR safety. So you can see the eribulin is the winner among this. As you all know, eribulin is clearly indicated in heavily pretreated TNBCs, and the graph of eribulin is upper compared with the other regimens of treatment of physician choice. So coming to the subset analysis, you can see in the subgroup analysis also the triple negative, the eribulin fared much better, and it was mostly the subgroups in the eribulin shows that it is shifted to the left, suggesting that all favored the eribulin arm. The side effects were the routine side effects of neutropenia, leukopenia, and there were not much serious side effects, but neuropathy, as we all know with eribulin, was more. So, eribulin versus capecitabine in metastatic breast cancer after anthracycline-based and taxane-based therapy, study 301, in which it was compared, and here also eribulin had a higher efficacy than the capecitabine. Median OS was 15.9 versus 14.5 months. And p-value diagnosed at young age with specific subtypes or with who had a family history of breast or ovarian cancer should be referred for genetic testing and counseling. Patient factors coming to less than 50 years of age, diagnosed of breast cancer, less than 60 years of age, a diagnosis of TNBC, diagnosis of bilateral breast cancer, history of ovarian cancer at any age or in any first or second degree relative, family history, who had been diagnosed with first degree relative with breast cancer at 50 years or less than 50 years of age, greater than 2 first or second degree relatives diagnosed with breast cancer at any age, any male diagnosed with breast cancer, and a patient belonging to Jewish heritage. This was the Olympiad chart, which emphasized the role of olaparib in patients with germline BRCA1, BRCA2 mutated, HER2 negative metastatic breast cancer. And basically, patients who HER2 negative patients were with germline BRCA mutated TNBC or hormonal receptor positive, which were HER2 negative and which were treated for less than 2 prior lines of for the metastatic breast cancer, and or if not suitable for ET and had progressed on ET, they were considered and given the olaparib versus other chemotherapy until progressive disease or unacceptable toxicity. And primary endpoint was PFS, and secondary endpoint was time to progression, OS, ORR, safety, quality of life. You can see the PFS is clearly high with olaparib, and the p-value is significant. Median PFS is also high, and the OS is also OS. I think OS is not matching up to the other chemotherapy. The OS is p-value is not significant, and the curves are merging. So coming to the adverse events, as expected, the adverse events with olaparib was anemia, and which anemia was common. Which the orange ones include the adverse event, nausea, anemia, and vomiting, neutropenia, diarrhea. This coming to phase 2, talazoparib in germline BRCA mutated, mutation positive metastatic breast cancer. This was a phase 2 study. Patients with germline BRCA1-2 mutation positive, ECOG PS0 to 1. Primary endpoint was overall response rate, and it was you can see cohort 1. It was divided into cohort 1 and cohort 2, and basically in this also in patients with germline BRCA mutated, talazoparib was the winner, and phase 3 AMBRACA, talazoparib versus physician's choice of chemotherapy in germline BRCA mutated breast cancer, in which patients with germline BRCA mutated who progressed on greater than 2 previous lines of chemotherapy for metastatic disease, including taxane and anthracycline adjuvant metastatic setting, were given talazoparib or physician's choice of therapy. You can see the various therapies: capecitabine, eribulin, gemcitabine, vimbrolimab. Primary endpoint was PFS, secondary endpoint was ORR, OS, safety. And clinical data on the use of immune checkpoint inhibitors for patients with metastatic TNBC. This was the Keynote 086 study in pembrolizumab in patients with metastatic TNBC and who were given greater than 1 systemic therapy, cohort included patients with progressive disease after one systemic therapy for metastatic TNBC. Tumor biopsy was available for PDL1 evaluation, and cohort B included PDL1 untreated PDL1 positive metastatic TNBC, and they were endpoints was over response rates and overall. And secondly, pembrolizumab was given in the routine schedule, and treatment was continued until 2 years or until progressive disease. Imaging was done every 9 weeks for 1 year and every 12 weeks. And response was studied by RECIST criteria according to the immunotherapy RECIST criteria and the PDL1. So coming to the response rates, you can see that in the PDL1 positive tumors, the response rates were slightly on a higher side versus the negative versus the patients who were not PDL1 positive. And this you can see the graphs which are merging in the PFS and the OS. There was not much difference between the PDL1 positive or the PDL1 negative patients in PFS and OS, and the graphs have merged with each other. These are routine adverse events associated with pembrolizumab, which can immune-related toxicity. And we continue करना
Yeah. Continue after this topic, so continue for another 2 minutes.
Phase 2 tonic nivolumab after induction radiotherapy or low dose chemo in metastatic TNBC adopted non-comparative trial, in which TNBC with less than 3 lines of palliative chemotherapy was given induction treatment, doxorubicin, cyclophosphamide, cisplatin, no induction, followed by nivolumab in the 3 mg per kg, the standard dose. Nivolumab after induction radiotherapy MSI high or deficient MMR solid tumors that have progressed on prior treatment and with no satisfactory alternative treatment options. So coming to the frequency of MSI high tumors in breast cancer after chemotherapy treatment, you can see in the regimen the highest propensity of MSI high tumors is patients who are treated with high effect regimen and other than that AC regimen, TC regimen, carbotaxane did not have resulting MSI high tumors. So this is the enzalutamide trial in patients with AR positive metastatic TNBCs. Patients with AR positive metastatic TNBCs, ECOG PS0 to 1, and were given enzalutamide until progressive disease, and primary endpoints were 16 weeks response was 24 weeks, overall response rate PFS OS, and you can see in patients with AR positive the response rates were quite slightly higher in with enzalutamide in AR positive patients, and you can see in patients who had greater than 10% of AR receptor positive had a greater response rates with the and greater PFS with the use of enzalutamide rather than the who had AR less than 10% as expressed by IHC. So,
can we do a conclusion?
Sorry.
Because it's a very vast.
Current standard treatment options for patients with TNBC remains chemotherapeutic approaches. Factors for selecting optimal chemotherapy for advanced disease includes previous regimens, potential for residual toxicity from previous therapy, need for disease control, and patient preferences and lifestyle. And PARP inhibitors have demonstrated benefits versus chemotherapy in patients with TNBC and with BRCA mutation positive. Immune checkpoint inhibitors have shown promising efficacy in patients with TNBC, particularly in previous untreated patients and in combination with chemotherapy. And additional targeted therapies under investigation.